Good evening and welcome to tonight's webinar. My name is Eric Hughes and I'm the product manager for Osteogenics. Before we get started, let me address how we'll be interacting tonight. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we'll try to get them answered during the end of the webinar. Once the webinar is completed, you'll receive a feedback survey in your email. Please complete that survey, and once completed, you'll receive your CE certificate. Tonight, we're joined by Dr. Fadi Hassan and Dr. Dimitri Ivanov, also known as the Perio Amigos. Dr. Fadi Hassan is a board-certified specialist in periodontics and dental implant surgery. Dr. Hassan received his bachelor's degree in dental surgery from the University of Baghdad. He then immigrated to the U.S. and was awarded a DDS degree from the University of Colorado School of Dentistry and was awarded excellence in periodontics. He continued his postdoctoral education in advanced periodontics and implant dentistry residency at the Virginia Commonwealth University, where he earned a Master of Dental Science. Dr. Hassan holds a position as a clinical assistant professor at VCU School of Dentistry and practices in the DC, VA, and Maryland areas. Dr. Dimitri Ivanov is a board-certified specialist in periodontics with a focus on the treatment of periodontal disease and hard and soft tissue augmentation, as well as dental implantology. Dr. Ivanov received his bachelor's degree in biological sciences from UC Santa Barbara, graduating summa cum laude. He was awarded a DDS degree from the UCLA School of Dentistry and continued his postdoctoral education in advanced periodontics and implant dentistry, residency at the Veterans Hospital of West Los Angeles and the UCLA Medical Center. Dr. Ivanov is a former clinical instructor of periodontics at UCLA School of Dentistry in Westwood and UCLA Venice Dental Clinic, and he practices in the Los Angeles area. Gentlemen, welcome. Great to see y'all.
Thank you. Hello. Thank you.
I think we'll have Dr. Ivanov. We'll be turning it over to you to kick us off tonight.
So welcome, everyone. We are the Perio Amigos. I wanted to welcome you to this webinar. We're super excited to share things that we do in our daily practice, specifically things related to soft tissue and aesthetic zone, especially some of the challenges and complicated things that we're going to be discussing today. I just wanted to share or thank Osteogenics for great support over the last couple of years. So since we've been growing a Perio Amigos with Fadi, Osteogenics has been by our side. It is not just the support, but also the products that we use in daily practice. This is just a few that I use or things that I cannot be practicing without on my daily routine clinical practice. Novabone for sinus augmentation, Cytoplast, a microderm, which is a new dermis tissue developed by or introduced by Osteogenics. Of course, glycolon sutures. There's not a day or an hour that I don't use glycolon sutures. I'm sure Fadi is very similar to that. And of course, Cytoplast singles. Been using that since residency, and I can't see myself not using it. We're going to see some of the clinical cases today. We're using these products that we use, like I said, with a great success. We are the Perio Amigos. We've been around since 2021, doing 4+ courses, clinical courses a year to general dentists and specialists all across the United States. We have a great schedule for next year. If anyone is interested, please check out our website, perioamigos.com. We have 2 very special courses coming up with 2 great other specialists that will be joining us. So please check us out. So before we jump in, I wanted to start discussing a topic of restoratively driven implant therapy, which is all what we know is basically all implants that we plan should always start with the restorative component in mind, meaning that restoration is planned in the most ideal position, and of course the surgical plan is made second. And this concept or this topic is very, very much universal across a variety of implant therapies: posterior teeth, full arch dentistry, and of course the aesthetic zone, where room for error is so slim, and that the ideal restoration may lead to ideal results. And of course, if we not clicking through. But to be able to practice this restoratively driven implant therapy concept, we have to have good zone of or good heart and soft tissue volume to be able to deliver these highly aesthetic cases. And of course, the more we practice implant dentistry, the more we realize that soft tissue will always be an issue. Even though we had great bone, the soft tissue will always be an issue terminally, whether the implants were done 4 weeks ago, it can lead to devastating problems, or the implant's been in the mouth for 22 years, right? Most of the implant complications will have a very significant soft tissue component. And the soft tissue, not only important for the beautiful aesthetics that we see as in the aesthetic zone and as well as posterior areas, but also important for long-term maintenance. And I wanted to share those 3 factors that we greatly pay attention to, specifically in the aesthetic zone, that not just develop beautiful aesthetics, but also give us a beautiful maintenance over a long period of time. The first is the zone of keratinized attached tissue. If we look at the literature, having at least 2+ millimeters of keratinized attached gingiva allows us for better maintenance. There's better plaque control. We tend to see less inflammation. And of course, we develop less and less recession within time. And that ultimately leads to better bone maintenance. The second component is having good tissue thickness. It's the quantity component of the connective tissue, and specifically in a horizontal dimension. We want to have at least 2+ millimeters of horizontal connective tissue thickness. That always gives us a better likelihood of more papilla fill, because the wider the base of the papilla, the more likely you're going to be able to build higher vertically. There's absolutely less recession over time, and there's the research shows that there's 5 times less crestal bone remodeling with the presence of good thickness of the connective tissue. The last component, which is extremely crucial, is the quantity in a vertical dimension. Having at least 3, preferably 4 millimeters of vertical connective tissue thickness above the platform of the implant protects basically the bone. That equals to the biological width, maintenance or development, and it directly proportional to the proper depth of implant placement. Of course, we have to consider other things like thickness, pre-existing thickness of tissue, but if we are looking at the implant placement, always have to be relative to the proposed gingival zenith and where the platform is going to be with respect to that 3 to 4 millimeter of soft tissue thickness. So, and the same concept is, of course, true for the posterior areas. It's not just the aesthetic zone that is crucial to have these dimensions. It is universal factors. And as much as we love seeing these beautiful pictures of developed tissue ready for beautiful restorations, we kind of have to think about what we start with, because a lot of times we are starting with a lot of what we call risk factors such as gingival recession or vertical root fractures. We have absence of the buccal bone. We have periodontal disease, or we have very significant complicated defects surrounding our teeth, which includes papilla or adjacent teeth for that matter. And these generally, universally, are many of the risk factors that we see that will be involved, usually present at the start of the case. It is our general rule or general goal is to really try to identify these risk factors and hopefully mitigate the challenges or reduce the challenges that we may encounter during the case. But a lot of cases, a lot of risk factors we can control. Some of these are appropriate treatment planning, right? Looking at the CT scan. Proper 3-dimensional positioning of the implant, using a surgical guide or free-handed dentistry. I mostly do mine free-handed, of course. Of course, some of them can be guided if it's more number of implants introduced or a full arch. But also importance is apical coronal positioning or depth of implant placement, which sometimes might be overlooked. Implant diameter. We don't routinely need to place 5 millimeter diameter implants in the aesthetic zone. In fact, Fadi and I are very similar. We place the narrowest diameter implant in the aesthetic zone to have more buccal bone, because we want to have a jump gap that's greater than 1.5 millimeters for that regeneration of bone to have thicker buccal plates. If we have a bone deficiency, we're able to augment that. If we have a soft tissue deficiency or phenotype deficiency, we are able to augment that with the soft tissue graft. And of course, one of the most important factors we can control is provisionalization, being able to develop tissue or preserve the tissue with the provisional, with the temporary. And we have a full control of the restorative or final restorative. Of course, we're always work with the restorative dentists. That is a lot of times we'll be restoring, but we are able to navigate and help those restorative dentists how to restore certain cases in a better way, perhaps. So before we, or at this point, I would like to discuss this case, and I wanted to introduce kind of a review some of these risk factors that are already present at the start of the case. So this was a 54-year-old female patient that was referred to me from a friend of mine from dental school. She came from quite far away, driving across town to see me. Hasn't been to the dentist. She's actually related to the office manager of the practice that was referring to me. So she went to see the dentist because she developed a little fistula here. As you can see, just midway through the keratinized gingiva, there's a red spot. That's the fistula. She had some soreness and discoloration of the tooth. Fairly healthy patient, non-smoker, but mild to medium or medium to high smile line, which is in the aesthetic risk assessment can be a challenging case. So let's look at some of the risk factors that we see. We have a buccal bone loss. There's a maybe 12 millimeter pocket on the facial. There is also periodontal bone loss on the adjacent tooth number 10, the lateral incisor. There's also 6 millimeter probing depth along the surface of that, probably secondary to the resorption. As you already understand, there's a fairly significant resorption, and there's recession on the facial aspect of tooth number 10. So let's take a look at what are the options that we have when we're planning these cases. We have to ask ourselves, are we going to replace the tooth immediately? And if we're doing immediate, are we going to replace the tooth with an immediate provisional? So that is the question that usually has to be answered by a surgeon, because not everybody has the skill, not everybody has a certain certainty that they will be able to achieve certain things. So if someone is not sure, I always recommend stage the case. Stage the case because you're able to control individual steps much more easier, especially if we haven't done as many of a particular case alike. So soft tissue management, are we going to be managing that tissue at the time of a removal of tooth and an implant, or are we going to do it later, right? We have to augment the volume. We have to be able to augment the papilla if there's a papilla loss. And we also have to augment the recession that's currently present on number 10. And then, of course, we have to deal with the provisional. So in the cases where I have some periodontal involvement on adjacent teeth, majority of times, especially if I have a recession or I have periodontal pocket on adjacent tooth, I tend to stage these type of cases. Although if we can place the implant within the bony housing and can augment the contour of the bone, Fadi had shown many beautiful cases like this. We can certainly proceed with that. But again, proceed with caution. This case, I decided to stage, again, for the reasons because, number one, there was a periodontal involvement of adjacent tooth. Number two, I wanted to manage the soft tissue in a subsequent step a little bit better. And not having the implant in place there would give me that a little bit more control over that. So tooth was removed. At this phase, what we're going to be doing is just augmenting the bone. This is Ossix Plus placed over a cortical cancellus mixed with a cortical allograft, just a pure allograft. There's no autogenous bone. And in the second step, this is not the exact case, but this is a case alike because I did not have a stabilization of the main brain picture from the case. So I'm showing you a very similar case. Using glycolon suture, this is our workhorse for this type of internal stabilization of the membrane. As a periosteally stabilized membrane here, Ossix Plus. I usually like to use glycolon sutures. There's two different options to do this, either internally, leaving the knots on the inside, or we can leave the knots on the outside, whichever the preference is. Again, based on your clinical experience, there is honestly no right or wrong. So whichever way we want to do this, it's up to the clinician. If you're interested in learning this technique, there's a fantastic paper that was published quite a while ago in 2016 by Urban and Homley Wang that describes exactly this technique with the periosteal stabilizing sling sutures. And we cover this technique in our course in quite detail, as well as practice it on the pig jaws as well, if anyone is interested in that learning. So going back to the original case, I love using this technique of a double membrane. I use a cytoplast membrane right on top of the Ossex Plus membrane, which allows me to avoid two things: distortion of the mucogingival junction, and allow me to avoid primary wound closure. That allows me to, in turn, preserve the keratinized tissue. In fact, I gain keratinized tissue. And I love the seal of the PTFE membrane because in the several days, those little dimpled areas on the surface of the membrane will be attached and sealed by the tissue already. So we have a nice seal from the saliva, from oral environment, and things are protected on the inside. Usually I like to remove membrane around 4 weeks for something like this. You can see this beautiful keratinized gingiva fully covering the membrane that's underneath. The bone graft is internally protected, secured. And usually I would give a horizontal defect like this at least 6 months to heal. And this is a picture that a patient comes in after 6 months, and we have to ask ourselves, are we ready to place the implant? In bone, on the CT scan, is quite good. What we are deficient in here is the contours and the volume of the soft tissue. We already knew we had a deficiency in the or going to have a deficiency in the papilla because there was some periodontal attachment loss on the adjacent tooth. And of course, due to shrinkage of the tissue, condensation of the graft, we had lost some of the volume. So papilla loss, which is a vertical deficiency, buccal tissue contour loss, horizontal deficiency. And we also would like to address the recession on the facial surface of tooth number 10. So let's take a look what we're going to do. The first step, of course, is to place our implant. We would like to place our implant at least 3, if we can, preferably 4 millimeters below the proposed gingival zenith. This implant, in appearance here, it might be appearing a little bit shallow. I did drive this a little bit deeper, and I profile the bone. Make sure we always profile the bone to allow for that restorative component in the future, because we're going to be burying this implant with the primary closure on top with the graft. And in these cases, I like to use a slightly shorter 2.5 millimeter height healing abutment to give me that tenting effect. So place the implant into the proper depth. And if we are attempting to grow papillas in the vertical direction, yes, we could try to harvest a tuberosity graft or a free connective tissue graft and layer it on top. But the most predictable technique, at least in my hands, to get height and good maintenance of the height is by using a vascularized pedicle grafts. Pedicle grafts, or also known as a VIP CTGs, they come with its own blood supply, right? It's still attached to the source of the blood supply at the incisive foramen area. It's got that's the reason why these grafts remain thick as they're healing, meaning they maintain volume. And then the next step is to stabilize the graft. The soft tissue grafts must be stabilized in a similar manner as in any bone graft, because there has to be no mobility. The more mobile the graft is internally, the more likely it's going to shrink. So our goal is to stabilize this graft. What I use here is a double graft. I harvested a piece of tuberosity, and that will be growing papilla on the mesial aspect and the buccal contour. And the scarf of the VIP graft is going to be building the papilla of the lateral incisor, and also growing or maintaining the tissue volume on the facial surface of tooth number 10, because we have that recession. So we need a lot of tissue volume to support that height. And of course, primary wound closure, we try to be as passive as possible in a similar way as we close any GBR case, a bone augmentation procedures, right? We don't want this flap to open. That may cause a variety of issues that we can see. This is a good view of an X-ray that's showing use of a 2.5 millimeter height healing abutment, because again, that we want as much height as possible, and that healing abutment gives us a little bit more of a maintenance of the vertical height, so the tissue doesn't sag into the platform of the implant. And that also protects, honestly, if anyone places implants slightly subcrestally, we see bone growth, right? Having a taller healing abutment internally will prevent that bone growing over the platform of the implant and impeding seeding of the restoration in the future. So 2 months follow-up, this is usually when I will be temporizing the case. Why? Because I had enough time for the graft to vascularize, and I also had enough time for the implant to integrate. So 2 months is minimum. If you want to wait 3 months, that's even better because tissue will be a lot more vascularized. I make my temporary screw retain chair side provisional, and I always temporize with, or try to temporize with the critical contour, which is the proposed temporary zenith, a little bit shorter of the final zenith, so I have a little bit more tissue to work with. So in the final prosthetic, the general dentist can idealize the position of the zenith by pushing on it with a final restoration. So 1 month post-temporization, we're developing beautiful midline papilla. Let's take a look how it looks when we remove it after 2 months. I actually added a little bit of contour to the distal. That's why I was able to take this photo. And this is already about 4 months from the final. And this is how we sent this patient to the general dentist. I wanted to show you the 1-year follow-up. This beautifully restored. This was probably one of the very, very, very nice restorations. This, done by this general dentist. I'm working with him obviously for the first time, but I was very impressed. I will show you the X-ray in just a second. But amazing contours, beautiful. How he dialed in the gingival zenith in the position, and the color matching is almost ideal. So, and a beautiful lingual screw axis, so couldn't ask for a better restoration. Let's take a look at the PA. She came back after this is actually a little bit more than a year and a couple of months. We took a PA. Again, this is quite what you're explaining to a doctor is a quite ideal emergence profile that you see. Very narrow. It's not impinging on the bone. It's not impinging on the soft tissue that we've developed. You got basically everything perfect that we've covered. The amount of keratinized gingiva. We have a horizontal tissue thickness. We have a beautiful vertical tissue thickness, and we had a very nicely controlled restoration by the general dentist. So again, couldn't be happier with the final results. So as the final thoughts, it's very, very important to have adequate treatment planning and case selection, and especially doctors that haven't been experienced in a complicated surgical cases, try to stage these certain things. It is absolutely okay to stage the case and try to identify all the risk factors beforehand, because most of my complications is usually when I probably thought that the risk factor was too small to cause a problem later, and it blew up on me, right? So do not hesitate to stage to increase case success. I'm okay for patient waiting maybe a few more months for if you believe that staging is going to give us that basically one miracle at a time. This is what I was taught in residency. In complication cases, plan more but do less. This is pretty universal. Always over engineer, and then if things don't need certain things, both of us win. The patient wins and I win. Tissue training in the aesthetic zone is absolutely must. I always say to the patient, without comparing to something, I say it's like eating peanut butter sandwich without a butter. I mean peanut butter. You're eating peanut butter sandwich, but there's no peanut butter. That's how important that the tissue training using a provisional. And I think Fadi would agree on that topic with me as well. So I wanted to thank you for your attention. And again, Perio Amigos is our brand. We've been growing together with Fadi. Please check us out if you haven't already. We got a variety of soft tissue and a hard tissue courses coming up in 2025. Unfortunately, our October course is fully sold out. We have a little bit of wait list. So if you're interested, sign up on our website for the mailing list. We send out a fairly regular emails with the clinical cases like I just shared with you, but in more of a write-up format, going through each individual step, as well as we share the upcoming information on our courses. Precision Perio is a brand of mine that I'm building a practice in here locally in South Bay. Hopefully, at some point, I'll have my own practice very soon. But thank you again for the attention. I really appreciate it.
That's a lecture you can't beat.
Thanks, bro.
I'm going to try my best, man.
Oh man. So, okay, I'm excited to see what you got. Whoa, that looks
So,
that looks
so this
very
is
simple.
very simple. The 3-year case, so we'll have a chance to kind of show the step by step how we approach this one. But yeah,
Fantastic,
let me.
fantastic.
So this is. I mean, you guys saw what Dimitri showed, and literally touched up on the points really specifically as far as like taking your time, staging the cases, developing the hard tissue, the soft tissue. And what I've learned from Dimitri over the last literally 3 years is really appreciating his soft tissue skills, the way he develops it, and recently be getting more into doing that combination between the VIP CTG and the tuberosity grafts. And hopefully we'll have a case to show and post for you guys very soon on whether Instagram or in our courses. So I'm glad to share with you guys very soon, hopefully too. But kind of jumping forward, and we'll show a couple of cases how we kind of manage those in my practice as well. So again, wishing my brother Dimitri, hopefully he opens his practice soon. Can't wait to visit when that happens. Very excited for him. It's been an incredible journey, and nothing but success to this guy. For me, I opened my practice last year, literally. So I'm still baby in my practice and learning a lot as I'm going away, going with it as well. But going on this case, this is actually a 3-year process of a case. This young gentleman who was about to finish college had a history of trauma when he was a kid. So this tooth is ankylosed for a very long time. You can see tooth number 8. As you can see, what it replaces right now is just I think like a denture tooth that's been splinted to the adjacent teeth with nothing but composite. So referred to me by a very good orthodontist of mine, and the goal was to extract that. It's pretty much there's root resorption at this point in time, and there's no buccal plate, completely missing. So the goal was to extract it and kind of work our way between perio, ortho, and then go to the final restorative phase. So you'll see the timeline sequencing with this case as we move along with it. So again, so the first step is what we see is, first of all, there's a high frenum attachment associated with this one, very little keratinized tissue. The tissue is very facially displaced. There's root resorption. You can see some coloring, but kind of very similar to the case that Dimitri was showing. I had no idea what case he was showing, so this might be a little bit of a coincidence as well. But what we did was, we generally, of course, we did our incision design. We really had to really explore as far as how much, of bone we are going to rebuild technically in that area. And as far as flap reflection, we pretty much went to almost to the floor of his nose. You can see the nasal septum associated with this one. And we took it out, cleaned it very carefully, preserving the remaining tissue. So all our incision design was literally done at the mucogingival junction. And once we did that, then we were able to pack, the bone into the area. There's just simply, cortical cancellous mix, FDBA, that we place in there. And then we put a nice membrane. I think this was like maybe a Salvan Renovix membrane that we used maybe 3 years ago at the time. And again, using glycolon sutures to really do a periosteal mattress suture technique, as was described by Urban back in 2016, and then really stabilizing it. I think the most challenging thing when I was looking at this case at the time was like, all right, I made this incision. I reflected the flap. I'm at the floor of the nose now. We cleaned everything. We did the bone graft membrane. Now the question is, how am I going to literally kind of working my way and stitch everything up, because it looked like a jigsaw puzzle when I was trying to see how I can really place my attached tissue. So you'll see there's a semi-lunar suturing in one area. There are like small interrupteds in other parts. So I was literally trying to find a way, how can I, reestablish a new width of attached tissue based on where he previously, presented with. So this was an immediate post-op that he left with that day. Fast forward 4 weeks later, this is what the tissue looks like. So we're able still to get nice, good primary wound closure and really kind of maintain the mucogingival junction where it is. And then now fast forward 2 years later, this was when he showed up to me back in March in 2023. And his orthodontist comes like, hey, listen, I'm almost done with my orthodontic therapy. I think this is a good time for you to maybe start placing the implant. I might have maybe 6 months left to go, maybe a little bit longer, not too much. So you can definitely go place the implant. And if you think you need to add bone, it's a good time to do a little bit of a ridge augmentation. One thing I can tell you in advance is if you're doing an implant placement with a ridge aug, make sure the wires are off. I think I showed this to Dimitri in the past. I was like, it really kicks you in the hind if you don't take it out, because you're working in such a small area and there's not a lot of room to really fiddle around with and play with. So This was our incision design at the time. We went, kind of very similar to Dimitri's case. This is very much of a coincidence, but I'd like to show it to you guys as well. It's just kind of playing with the orthodontic bracket in place and also the wires. So with the paddle placement, again, the cool thing is you get to still see the bone augmentation that we did from 2 years ago. That's still really, semi well preserved, I would say, at the time. So we added more bone to the facial because I really wanted to improve the volume horizontally as well. And we use actually a 2 millimeter height also healing abutment for this case. So that way we can, also in case that there's for the slight vertical augmentation that we can add to it, kind of like a 10-pole approach. We added, again, Salvinorenovix, again, periosteal suture technique, using also glycolon sutures. Again, these are, like what Dimitri was saying, these are working horses. You can see that their tensile strength does drop down by about 50% at 2 weeks later. So which is really remarkable. And the cool thing is, I'm sure all of you guys know this, it's a monofilament synthetic, does not wick or collect bacteria. I'm a huge fan of having my sutures on the outside because I've had previous experiences with inside. Sometimes it might be, if it's too short, it might poke through the tissue and can introduce bacteria to it. So I tend to put my sutures more externally versus internally when I do use for membrane stabilization. This is your occlusal shot, again, how I have it nice and stabilized as far as the membrane. And this is your immediate post-op using PTFE sutures, again, by Osteogenics. And these are, again, our working horse for our ridge augmentations. I mean, they're strong, they keep the tissue intact in place, and they're using glycolon for our immediate, for anything interrupted for the remaining part of the incision design to get really good primary wound closure. Again, this is your occlusal to show how we really close it up, again, from occlusal point of view, again, using glycolon as well as PTFE sutures for this one. And now fast forward post-ortho. This is now August in 2023. So this is exactly about 5 months later. And, we're not ready to do our second stage yet. But again, what Dimitri was showing you guys, we look at the soft tissue deficiency in this case. And in his case, he does have papilla loss both mesially on that, let's say, the mesial aspect of the future crown, as well as the distal aspect of that future crown, which represents the mesial of the lateral and the mesial of the other central. So my approach, again, in this case was slightly different than Dimitri. You saw me previously did a beautiful VIP CTG with a tuberosity graft. For me, like to use sometimes the tabletop approach. He did not have a huge tuberosity to really work with. So I did take a big piece of a deepthalized free gingival graft, and everything was done as split dissection to leave a layer of periosteum intact. So this is the first layer of a connective tissue graft that was sutured with a 6-0 vicryl suture that we kind of stabilize it with. And then we added a second layer of a connective tissue graft, so another layer on top of it. So one more horizontal, one more of a vertical. And this was kind of slinged around the adjacent teeth with the sutures. So really I can improve my both horizontal and my vertical dimension with this as we tend to close it up. Immediate post-op, you'll see some 6-0 polypropylene sutures. And again, also some glycolon sutures for that internal mattress to really stabilize it and get that thing nice and closed really well. Fast forward 4 weeks later, you can see some really good tissue volume that we were able to develop both vertically as well as horizontally. However, we do see sometimes that tissue retract a little bit. So you can see the midline papilla, that tissue is retracting a little bit. And the question is, why does that happen? Is it because of the quality of the tissue material, the connective tissue? Would have been better if I did do a VIP CTG and see if I can harvest a little bit of a tuberosity, however size that is. I really do believe that tuberosity grafts and VIP, the tissue is much thicker, more robust. We know that tuberosity grafts do have a tendency to increase in dimension over its lifetime by almost 20-30%. So that's the beautiful thing about you using those, autogenous grafts, that it gives you that extra kick if you really need for that volume building, especially in a vertical dimension. But 3 months later, you can see kind of things are slightly stabilizing at this point in time. So this is now November, fast forward November of 2023, almost 3 months after our soft tissue augmentation. And now we're going to do a simple second stage. However, I know where my implant is. I'm just going to do a small punch. I don't want to really disturb the mesial and the distal aspect. Otherwise, there is a slight chance that I might lose that dimension that we've tried to create. So it's being more on the conservative side and just doing a minor punch for this case. Now, occlusally, you can see, again, my palatal, my kind of emergence or my cingulum emergence, I went for a screw-retained access Once I get to that level, then 2 months later, I'm going to put the patient in provisional. So this is 2 months post-provisionalization that we delivered for the patient. I'm going to let this kind of sit down and kind of settle in for, again, 2 months after we provisionalize it. And then I'm going to send this patient to the dentist that we all kind of agreed on where he's going to be seeing. And she's going to work on the 2 front teeth. So she's going to work on number 8 and number 9 to kind of really work on the contact points to see they're putting the right amount of pressure that we need to really kind of slowly create that midline papilla over time as it develops. And this is your occlusal emergence. This is by January 2024. So again, this is 2 months post-provisionalization. And you can see now how we're able to develop, again, a good buccal contour, good midline papilla, as well as the distal as well. Final emergence, this is a final definitive crown that was delivered about 4 months ago in April of 2024. Again, we started this exactly in April 2023. So you guys get to see how we started back literally exactly 3 years ago, and fast forward now in 2024 with the definitive crowns for this case. So hopefully we'll get to see more of that papilla growing in between the 8 and 9, and also between 7 and 8 as time goes by. But again, just it's nice to see how this young patient, went through the whole process at the age of 22. Now he's almost 25 years old, going to be 26 soon. Where he started with trauma and history, doing through braces, perio, and then restorative dentistry, and how we finish this case. So it's kind of a nice a good, I would say, collaboration between different specialties to get where we are today. So that's kind of our first case, how we can manage this one. And then we'll go to our second case. This one is, instead of being a 22-year-old patient, this is almost a 72-year-old patient. So fast forward like 50 years later, okay? And her first thing when she comes in, tells like, I want a date. I want to make sure that by the time I leave, I like to have a date when we're all said and done. It's like, all right, cool. Let's see what you have. It's like, I only want to focus on one tooth. We take a CT scan for her. It's like, well, literally you have 3 teeth. That's a problem, not just one. You have 8, 9, and 10. One has a history of apico. There's no bone there. Other one has advanced periodontal disease, which is number 9 on the lingual, on the palatal. And number 10 also has really, severe mobility, almost grade 2 mobility. So it's like, honestly, all 3 need to come out. But I'll show you what it looks like when we really open it up. And you get to see the amount of the destruction that there is. That's your palatal bone with a white outline. You can see all those infections, and from her periodontal disease, her history of apico. You can see some discoloration, the soft tissue in the bone from the amalgam that I used for the apicoectomy at the time. So again, a very old case that was done. And our goal right now is to rebuild the hard and the soft tissue for this case. So I was like, listen, you have to be patient with me. This is going to be a process. It may take a year and a few months until we really try to get things built as best as possible. And the more you are patient with me, the more we are able to get more done for you in the aesthetic fashion that hopefully that you can, that you're imagining. So this is a really nice mixture. This is MDBA with, PRF, creating sticky bone. So just kind of show you, as when we have a CT scan in comparison to what we take intraorally with pictures for our case. And then we're going to add, again, this is your facial shot to compare. And then we're going to add the Ossix Plus membrane. And again, this is a double layer technique that I do like to use for those, big cases. And again, using glycolon sutures as your periosteal mattress stabilization approach. Again, like I mentioned to you guys earlier, all my suturing is usually having my notches on the external aspect of it, not inside, just because of my previous experience with it. Now, with immediate post-op, again, it requires a lot of tension-free closure, which means you're literally going almost to the, to the lip, and you're literally releasing that tissue, so you can get pulling that tissue all the way to the palate as much as possible, and pretty much it's almost free, and that's the whole idea. So that way, when swelling does happen, nothing opens up and retracts. So you're trying to do an eversion-style suture approach. So that way you can get really good wound closure. So using PTFE sutures for your horizontal mattresses, and then everything else is going to be using 5-0 or 6-0 glycolon, depending on what your preference is, and trying to close things up for your primary wound closure approach. So again, your occlusal shot, you can see here, and sorry for a little bit of the blood on the palate, but again, that's, sometimes you're taking the picture at the moment, so you tend to not pay attention to the minor details, which is a little bit of blood on the palatal aspect. But this is fast forward now, 6 weeks later, you can see really good healing. And this is at 4 weeks after the sutures have been removed. But what you see as well from the facial is that, there's a severe distortion of your mucogingival junction. Like pretty much her soft tissue is almost at the crest at this point in time. And you can see also there's papilla loss associated with it. 4 months later, this is usually my go-to time to start really working on the soft tissue part, recreating the mucogingival junction, or we're building the soft tissue more vertically. So in her case, I decided to go with, first, let's just recreate back her mucogingival junction, and what's the best way to do it. So again, this is your facial. So now my goal is as far as incision design, I'm doing everything split thickness so I can create a periosteal bed. I'm going to harvest a de-epithelialized pharyngeal graft, and I do like to use those for my anterior cases because I do find a better aesthetic blending and matching when I use a de-epithelialized pharyngeal graft versus using a free gingival graft. I feel like it gets more on that white color patch, and for aesthetic situations, when patients smile, I hate to see some of that color, discrepancy one side versus the other. So that's been kind of my go-to for the last couple of years. Stabilizing with 6-0 glycolin sutures, being very careful. And the nice thing about these, especially with 6-0, is that the needle size is so small that when you're going through the periosteum, it does not tear through it completely like we see with other companies out there. So that's the nice thing, is that the intricacy and the fineness of that needle head. So it makes our work a lot more easier and predictable when we're stabilizing those grafts. So 3 months later, this is how the tissue heals and matures. And like I mentioned, you see better tissue blending with the color wise. It's not too white. It's more of the pinkish side, as it heals. So after sitting down with the lab and planning this case for as far as implant placement, provisionalization. So again, you can see on the images on the both upper right and upper left side. So that's how we planned it. And this is the provisional try-in that we kind of communicate with the lab. One thing I did notice is that my provisional was really not what we discussed. 9 is longer than 8, and 8 is the same as length as 10. The design between 9 and 10 was just not really ideal. But at this point, patient is in the chair and the provisional is here. So it's like, all right, we're going to work with it as best as possible to make sure we can utilize it. And this is now your new dimension that we were able to achieve post ridge augmentation and soft tissue grafting. So we have a nice established, buccolingual dimension, good reestablishment of the mucogingival junction as well. And again, our design, so again, re-entry, this is now the bone that we were able to regenerate, again, almost 6 months later after we did our original augmentation. So nice, beautiful bone augmentation. The only question is every time I look at my case, should I have done this a punch approach? And I did a couple of punch and then placed my implant, did provisionals. Would that have been better for me to really stabilize and, preserve more soft tissue versus doing an open flap? I think a lot of times we like to open up those cases just to see what the bone looks like because we want to see, did we grow enough bone? Do we have then take that nice picture for our presentation / Instagram situation? So, you need to think about these cases if I have good bone in the CT scan, maybe it's best for the patient to do this case, maybe, just a simple punch and then adding the right amount of tissue from your prosthetics to really recreate that emergence profile. So I keep always kind of, looking at your case and then reevaluating one more time. So guided surgery, again, this is Straumann 3.3s. Again, like Dimitri showed you guys earlier, I do like this more the narrower for my anterior cases because I really want more bone to the facial aspect. In case for future remodeling, I don't have to worry about threads showing through and all that stuff, and gives me more room to develop that emergence profile with the process. And to make sure your prosthetics is in the right place, this is one way to really confirm as far as, is my prosthesis coming out from the emergence profile? So this is what you get to see. Now the cool thing is with this picture, you get to see also the deficiency with the provisional. And that's something that also we had to kind of suffer as a consequence during the healing phase, is that the lab, made the palatal aspect of number 9 slightly deficient. So when we're suturing things up and holding it, that we had a slight collapse in the soft tissue because we didn't have enough, structure of the provisional. That's something, unfortunately, I should have paid attention to during the surgery that I didn't. But it's just something for you guys to pay attention when you start doing those cases more and more. Again, so I do my provisionals. I pick it up chairside myself. I recreate my emergence profile. I kind of learned that back in residency. So we'll create the critical, the subcritical contours, and then I'll polish it chairside myself. It takes about roughly 30 to 45 minutes, give or take. But it helps me really see and understand the prosthetic part. So it gives me a good way to communicate with my restorative doctors and my prosthodontists, like, this is what I did. Can you mimic something like this for the final situation? I did add FibroGuide to the facial because I really wanted to make sure that I minimize any soft tissue collapse during the healing phase, especially with those cases that has a history of ridge augmentation and soft tissue grafting. Sometimes there's scar tissue. As the tissue heals, it tends to retract a little bit more. So just as a preventive measure, this is kind of my go-to approach to be just on the safe side, honestly. Immediate post-op, this is what it looks like. So there's a lot of internal mattress sutures to really kind of evert the tissue and push it up as high as possible against the prosthesis, just to anticipate the soft tissue shrinkage that can happen the next 3 months as this tissue is being provisionalized. So this is 3 months later. As you can see, there's already tissue collapse, between number 9 and number 10. And the question is, why did that happen? I really do believe that this did happen just from the design of the prosthetics on the palatal. Looks like there just was enough adequate blood supply from the palatal to the facial. Hence, we get to see some lack of vascularity to the tissue on that side. So therefore, it does tend to collapse, and we get to lose some of that papilla formation. So we had a discussion with my patient, like, hey, listen, I can do a simple soft tissue augmentation. I can go through the sulcus, and I can just add a simple connective graft, and I can beef it up, and it works really well. Try those several times, and you get some really nice papilla formation by you're just using microblades and micro instruments and micro tunneling instruments. You can go in and insert a graft literally in that pontic site, and then just elevate it vertically. At this point, fast forward now, she's almost a year into this, a little bit longer. It's like, honestly, I'm happy. I would like to just get my prosthetics, and I don't want to worry about me being in a S6 retainer or anything breaking. I think she went to at least 2 or 3 S6 retainers in that period of time. So send her back to the prosthodontist. And this was the final prosthesis that was delivered for her. So a little bit of pink porcelain that was delivered, at least between 9 and 10, and also between 8 and 9. I think she went to maybe 2 prostheses until they were finally able to get something that really was up to her, aesthetic, happiness, a happy spot, I would say. Again, this is our smile lip. So again, very low lip smile line. This is I was like, smile hard for me. This is what she was able to do. But again, the cool thing is she's just super happy and super pleased as far as what we were able to achieve for her. And with that, gets us exactly on the 20-minute dot. So thank you guys for your time, and hopefully we'll be open to questions for you guys.
Thanks, gentlemen. That was great information shared there. Appreciate it. Now it's time for the Q&A portion here. We've got some good ones coming in already. To hear from you, the Q&A button is at the top right of your screen. And a lot of these, I think you can both answer. And so we'll, maybe we can go back and forth. But the first one here is, I think was during Dimitri's case, is it says sometimes when using a DPTFE membrane, the tissue will recede away from the membrane and you could experience adjacent root exposure. Do you have variables that you look for when you don't place the PTFE at the crest? And have y'all both seen this, or?
Yeah, I understand the question. I think it usually happens when you overextend the membrane. The DPTFE membrane has to be placed at least 1.5 millimeters away from the root surface, at least for that papilla to reattach, for that soft tissue grow. You can't stress that enough. I think it's even says it in the instructions how to use it. So that's usually the case when tissue retracts and you develop recession. When you simply place too wide of a membrane into interproximal space. But if you trim the membrane the smallest possible just to cover the orifice of the soft tissue without touching the roots, and you have good initial tissue in the area, there should not be any problems of tissue retraction, unless the papillas are either traumatized or very, very thin to begin with, and we open them up, like when we open the flaps. So I always try to keep the papillas intact and maybe do a submarginal type of incisions if we have to open a buccal flap, keeping the volume of the papilla on bone. That's basically the only the only time, that I can see the problem happening, because I've gone through the same complications before. We just need to properly size the PTFE membrane. Fadi, what do you think about this question?
I mean, you answered it perfectly, exactly. I mean, the only time you get to see a recession is that if that membrane is so close to the root structure, and you won't have adequate soft tissue closure. I mean, pretty much the tissue will retract if it's just too close. So you need to, like Dimitri said, you need to have room for the papillas to reconnect, and that's a simple answer to it. So again, it's in the instructions. Just be a 1 millimeter, 1.5 millimeter away, and that's your safety zone.
Yep, exactly. And that's what we recommend as well.
And just to add a small thing, there are certain cases where we want to regenerate attachment. For example, if we're doing a socket graft and there is attachment loss in it proximally, and in the defect, for example, they have perfect buccal bone and a palatal bone, you can technically extend the membrane to the root surface with the hope that you will get some attachment gain in that area, and you basically have to assume that there's going to be no papilla in the secondary intention healing. But if we can get that stable clot up against our root surface, there is a chance we can regenerate. That's the only time where I overextend my PTFE membrane is when I'm trying to gain attachment on the adjacent tooth. If it's gainable, meaning that defect has to be perfect.
Okay, right. Next one is about some of the horizontal defects that you were showing. At what size do those defects get that you want to start adding something for space maintenance? Such as like tenting screws or switching to like a titanium reinforced or something like that.
I think the time I don't use a lot of titanium reinforced myself personally. I still have issues with it. Unfortunately, but tenting screws I use a lot. Honestly, I love them.
Okay.
For horizontal defects, if let's say you're crossing across the midline and you're talking about from 7 through 10, I do like to place at least 2 horizontal defects. If the defect is like really dipped in and I just want that extra security to make sure I get extra bulk, sometimes if the patient has a strong lip or, depending on their muscle attachments, I will consider sometimes adding a tenting screw just to kind of counter at the forces of their soft tissue. So that I have done. And so again, 1 to 2, depending on the site that I'm working with. And sometimes I use it for my vertical augmentation. I'll just add a couple of tenting screws and, do the bone graft membrane, and then I can actually just close it up nicely. And that does the trick for me. So that's been my experience with using, again, tenting screws, anything like that for my horizontal and my vertical. What about you, Dimitri?
Honestly, horizontal defects, and I'm with you on the titanium BTFE. I've done many amazing cases which look spectacular, but then there's always this 1 or 2 cases that make you rethink. Usually it's a soft tissue issue, always a soft tissue issue. Flap management, or tissue to begin with, those are very, very common mistakes. Or we did not trim the membrane short of the root. So that's the case. But tenting screws, for me, it's rare to use a tenting screw for purely horizontal defects, because if we're using obviously particulate allografts, we just simply need to overbuild that volume. We need to really add a lot of volume with acceptance of the fact that there will be some collapse or shrinkage horizontally, but in the purely horizontal defects, it tends to maintain fairly well. It's the vertical defects, in my opinion, that you really want to utilize maybe tenting screws, but horizontally, if we depending on also, like Fadi, you like to use purely corticocancellous allograft. You don't really use, you don't add additional xenograft, or you don't use additional cortical allograft. What I found in my experience, I like to use a little bit of a cortical allograft. I don't use xenograft. Neither of us use xenografts, but cortical allograft just slows the resorption process, so that kind of acts like a tenting screw. I only add about 20 to 30% of the entire volume. It does resorb, but resorbs slower. So majority of his allograft, 70%, and a 30% will be just cortical allograft. So it just increases the amount of cortical volume within the cortical cancellus, if you will. So it becomes a little bit more higher. And I usually only use it for very big buccal defects, and or if I have a buccal socket missing or something like that, just to again maintain the resorption or increase the resorption time. But horizontal defects, I don't find it as necessary unless, like what Fadi said, across the midline from canine to canine, and this portion right here is the highest likelihood of collapse. Maybe that's the spot, but I'm not a super tenter or person that use a lot of tenting in practice for horizontal defects.
Okay. Dimitri, you mentioned an article about a suture technique. What was that article again, and how can we find that?
Fadi mentioned that article as well, 2016, Homely Wang and Urban, Esteban Urban.
Okay.
There's probably 5 names. If you Google the name in the public,
Urban Lozada, and Lozada.
Yeah, just horizontal and mattress suture for membrane stabilization. If you Google that, it should pull up. You'll see this picture that I showed you. If you switch back to the slide that I had, we can show them exactly so they can take a screenshot of that. It was like,
okay.
I don't know if
we can go back to that slide exactly, but we can. I can get it from you, and we can put it out somewhere. To everybody watching. Next question is when you need to cantilever a lateral, for example, like a number 9 to 10, will you use a wider implant?
I might go for
question. I do prefer
I would prefer 4. That's what I would go. Don't do 5.
No. 4.1 or 4 is plenty. 4.3 if you really if you got a lot of bone to work with, but 4.5 is unnecessary. 4.0, especially if you're using an implant that's clinically proven to be strong. Straumann, for example, a titanium, zirconia type implant, we love using it for cantilevering a lateral.
Okay. Awesome. What kind of temporization methods did you use right after the first bone graft for the first patient, Fadi?
The first patient, that was honestly just a denture tooth that was stabilized to his adjacent teeth, like with composite. That was it. And I think his general dentist did that. His first dentist ever he saw. So nothing fancy. But normally for anytime GBR, I just use an Essex retainer. I don't like RPDs. Don't bring me flippers. I'll throw them away. So I write down my letter, please use Essex or fabricate Essex. If they're not going to do it, I will do it for my patients. I can send do an intraoral scan, send it to a lab, just come back with an Essex. Not a big deal.
Okay. All right, back to GBR a little bit here. How much do you typically overbuild the bone when you're doing GBR?
Always overbuild. It will resorb. That's the answer.
You overbuild with a notion that you're able to close it, because that's the challenge. And I've gotten into trouble many times over on the lower anterior where I'm so excited to get this beautiful thick bone graft, but you cannot close. So what you do is when you open the flap, you manage your periosteal release. Get that out of the way. Make sure you can mobilize flap very, very well. If you're having challenges mobilizing the flap, do not overbuild your graft. That's as simple as that. But there isn't like a proportion we want to overbuild 10 times the volume we anticipate. But if you anticipating 40-50% of shrinkage in what you need in the ridge, based on that, overbuild by 40% of what you want in terms of width. So there isn't a true math, I think, at least what I know. It's more clinical experience. Fadi, I think you're similar. But there isn't a special math formula to allow us to calculate, but try to overbuild by 40, maybe even 50% of the width you're anticipating to maintain. Or you have to understand that the bone that you're going to gain is maximum possible is the alveolar housing. That's the envelope of bone. You cannot grow more in even though you were always trying to build outside of the housing. Eventually, your body will bring everything to where it naturally occurs. So there will be a resorption.
Okay. All right. I think we've got time for a couple more. How far away do you usually make the periosteal release incision from the mucogingival junction?
That's a good question. I mean,
first of all,
I mean, you need to create it where if you're planning on doing periosteal mattress sutures, you need to make sure that you're at least, I would say, at least 2 millimeters away from the full thickness that you're planning on doing. So let's say I want to augment horizontal, let's say 8 millimeters, and also not just horizontal, but also let's say going more apical, another, let's say 6, 7, 8 millimeters, for example. My full thickness is going to be anywhere between maybe up to 10, let's say. So where's my periosteal release going to start? At least about 3 millimeters away from that most amount of like the flap reflection. I do not like my release personally myself to be closer to the my incision line or to the mucogingival junction for one reason. It's because when you apply the pressure and you're releasing that tissue, if it's very thin at the mucogingival junction, when you're going through with that needle, that's going to be the thinnest part. That means that area is going to be the first area for you where you're going to see potential necrosis or sloughing of the tissue. So plan your release to be farther away from your future where your needle insertion is. You want that needle insertion and you want that tissue to cover your membrane. You want that to be as thick as possible, in my honest opinion. So make sure your release is further down, really close to your full thickness flap. You have room for your periosteal mattress suture too, if you want to use that for membrane stabilization. So that's kind of where I want my release to be, is that, and if there's any anatomical structures, like you're talking about the mental foramen, you want to at least leave a good 4 to 5 millimeters distance away. So you don't want to cause any paresthesia. So there's also other factors you have to consider, but that's kind of how I like to think about it. Okay, if my incision release is going to be too high, and I'm putting my suture there, that tissue is so thin and weak and frail, there's a good chance I might just tear through it. And it's happened to me. So I would say just keep that in mind.
Dimitri, what about you?
Yeah, no, I'm following Fadi's recommendation, especially what he described is very important if we're using that periosteum to stabilize. And Fadi highlights it beautifully on a hands-on in our course, how you can tuck in the membrane right below that released periosteum, but that's the only way to achieve it is to go away from the mucogingival junction, because if you cut at the mucogingival junction, yes, perf is likely because tissue is super thin. I've perfed there a number of times myself. And you're not going to be able to bite that beautiful periosteum because it's going to be too coronal. You're going to want to bite more deeper to really hug the base of that graft. So away from the mucogingival junction, the only place I avoid is, as Fadi said, mental foramen. Unfortunately, we got to stay away from that as much as possible, especially when a mental foramen is very coronal. So we get close to the mucogingival junction.
Okay. All right. Final question here. With regards to GBR, what do you prescribe to your patients post-operatively?
Antibiotics and Motrin 800 milligrams. It depends on the size of the defect. If it's really big, I may give them something stronger, like a Vicodin, Percocet, depending, but not too much. I'm not a huge fan of giving narcotics, honestly, unless I feel like this case needs it. I do, also depending on the size of it. It's a small GBR. I don't do Medrol dose pack. If it's a bigger one, I will, just to minimize the swelling. I am a huge fan of local steroids, like dexamethasone. I'll just do it locally. Sometimes that's it for me. So anywhere between 4 to 8 milligrams, like just around the area. That really helps minimize the swelling post-operatively. So that's kind of been my go-to for my prescriptions. And mouth rinse, usually Paradex for like a week, not more than 1 week, because it just stains your teeth.
Yeah, I'm in the same boat. 600 ibuprofen pretty much for every patient that receives any sort of surgical, especially periosteal release. A larger GBR, like a traditional GBR, horizontal augmentation, vertical augmentation, medral dose pack, most likely, especially older patients, frail patients, thin tissue patients. They're going to turn purple and all kinds of yellow later. And Norco is rare. I don't give narcotics as much. I prefer just stick with ibuprofen and Tylenol. I tell them alternate every 3-4 hours. So take them together if you want. And then I've never written prescription for Percocet. Strongest one I've ever given is Norco. I don't even know what Percocet what the amount you would give because it's rare. I try to manage narcotics free, and I haven't used much Paradex lately. I've used Stella Life quite a bit for patients and or nothing, saltwater rinses. But steroids only for a very large traditional augmentations. If it's a socket graft with augmentation, never. It's too small of a site to consider that. And patients don't like steroids. If you ever taken steroids, makes you feel like you drank 10 cups of coffee and you can't sleep. You're like really on edge. Ran a marathon and your heart is racing. You're like all stimulated. So if I don't have to give steroids, I really don't.
Okay. Well, unfortunately, that's all the time we have tonight. I want to thank everybody that was watching and submitted some great questions. And just a reminder that the feedback survey is going to be sent out shortly. Once you complete that survey, then you will receive your CE certificate. Gentlemen, thank you so much for your time tonight. It was great to see you and catch up, and appreciate all of the information that you shared with us here tonight. So,
thank you guys. Appreciate your time as well.
It's our pleasure, guys.
Good night, everybody.
Have a wonderful night, everyone.